Good evening, good evening. Welcome to Instagram Live tonight with Dr. David Light, Breast Reconstruction 101. Please give us just a couple minutes as we wait for Dr. Light to join in as we and knowing your breast reconstruction options is imperative in our community. So welcome and thank you for tuning in. Good evening, how are you?
I'm doing well. How are you?
I'm good, thank you. How's your afternoon, evening going? Surgery today or?
Nope, in the office all day.
Awesome. So thank you so much, Dr. Light, for coming on. It's always a pleasure to have you on at BRCA Strong. Tonight, just so everybody knows, our topic is Breast Reconstruction 101. And for those of you that don't know me, I'm Tracy, the founder of BRCA Strong, where we educate, inspire, empower, and advocate for survivors, and thrivers, regardless of predisposition. And tonight, we have special guest, Dr. David Light from NIBRA, educating us again on breast reconstruction options. As for me, this topic is very imperative as I have been through a journey and want no other woman to face this. So let's welcome Dr. David Light, if you'd like to do an introduction.
Sure. Thank you for having me, Tracy. So as Tracy said, I'm David Light. I'm one of the partners at NIBRA Plastic Surgery, along with Dr. Ron Israeli, Dr. Randall Feingold, Dr. Jonathan Bank, and Dr. Peter Korn. And so the five of us have our practice is focused on breast reconstruction. We do a high volume of both autologous or natural tissue reconstructions like deep flaps, as well as implant reconstructions. And I'm excited to be here. Always have a lot of fun with you. I think these sessions are great. It's great to be able to reach out to those, no matter where they are, to be able to provide, important information to help them make a decision that's really critical in their life.
Definitely. Well, as we're starting this amazing conversation tonight, I want to leave it to all of you to know that if you have questions, we're more than happy to try to answer them as no medical advice is given. If you have questions, you can either put them in the comments or send us a question online. We'd love to help. And we did get several questions from our community. So tonight's going to be a different way than you and I normally talk and educate just on, our basic, options. But tonight happens to be a Q&A. So we're listening and out for our community that wants more education.
Absolutely. Yeah, I think I enjoy the Q&As. It's you always get new questions, and it actually educates me as well, because it kind of highlights sort of what people are wondering about, and where some of the shortcomings in breast reconstruction education may be. So I'm looking forward to it, and why don't we get started?
Perfect. So, how do we know what breast reconstruction option's best for us and what you're a good candidate for?
Right. So everyone is different. We all have different body types. We all have different goals as far as, what we're interested in as far as recovery time, what our aesthetic goals are. So the consultation and the exam is really the key to figuring out what options are available to you and what options are best going to align with what your goals are. So the patient history is where you sort of collect the information. You learn a little bit more about what their comorbidities are, what their risk factors may be, like smoking, previous radiation. The physical exam is a chance for you and the surgeon to review your body type, assess where you may have a little extra tissue in the lower abdomen, the inside of the thighs, in the buttocks, in the lower back. All of these are places where we will sometimes utilize tissue in order to perform a breast reconstruction. And then usually we finish up the consultation with reviewing before and after photos, so patients can actually see what each option looks like. And we try and match up as far as body types as well: tall, short, heavy set, super thin, different skin tones. And during that consultation is a question and answer period too. It's the surgeon's opportunity to learn what will make you happy. do you want to be larger? Do you want to be smaller? Do you want a breast lift at the same time? Do you want to use an implant? Do you want to use your own tissue? Review the risks and benefits to each option. And by the end of it, we should be, 90% there, if not 100% there, and getting the patient to a point where they're happy with the decision they're going to make.
As you and I know, it's just not one option for breast reconstruction, right?
No.
Like there's so many options out there. So would you mind taking a minute just to run through the options and
Sure.
expand a little bit? As some women, today I did a post and women were like, wow, I didn't even know this existed, on your breast reconstruction options. Because again, we've spoken before about how many women go in and see somebody who just does implants and they don't know about flaps. So
Right.
if you wouldn't mind to just share, the reconstruction options.
Sure. Yeah. I mean, I sort of break it down in my mind. There's always an option to do nothing and have no reconstruction. And some of those women will opt to undergo what's called an aesthetic flat closure. So you can just proceed with a mastectomy with no reconstruction, but that can leave you with excess skin and sort of contour abnormalities afterwards. And so an aesthetic flat closure is removal of all of the excess skin. And it's more of a aesthetic procedure for the chest wall because we're really not reconstructing the breast, but it will leave the patient, with a cleaner, neater, prettier appearance. And so an aesthetic flat closure or no reconstruction is always an option. If the patient undergoes a lumpectomy, there's a number of different oncoplastic options, an oncoplastic closure, an oncoplastic reduction or mastectomy, and these are all different techniques designed to rearrange the remaining breast after a lumpectomy to try and prevent any contour abnormalities. And if a patient is large breasted or their breasts are sagging a little bit or ptotic, as we would say, the reductions and lifts are a great way to combine a lumpectomy and really improve the shape of the breast. So we talked about no reconstruction, we talked about options for lumpectomy, and then sort of the third category in my mind is reconstruction after a mastectomy. And that gets broken down into either an implant reconstruction or a natural tissue reconstruction. If you go the route of implants, the end point is always an implant. It just matters, the differences would depend on how you get there. Do you go direct to implant and put the final implant on the day of the mastectomy, or do you do a tissue expander implant reconstruction? And there's a few different reasons on why you may do one or the other. And again, the physical exam and the history helps to make that decision. As far as the tissue flaps, which our practice is heavily focused on, there's a number of different options. The sort of workhorse or most common flap that we perform is a deep flap. However, there's many options. The inside of the thigh, you have pap flaps and tug flaps. You have gap flaps, which come from the gluteal area or the buttocks. There's flaps from the lower back, from the upper back. And so there's many different options. And again, the physical exam is the key there because that'll let us know, okay, how much tissue do we think you have in each one of these areas? And is that going to meet your goal, to be a B cup or a C cup or a D cup or whatever it may be? But at the end of this, we want to make sure that you're happy with the reconstruction and that we've met your goals. You may really want to have a deep flap, but if your goal is a C cup and you only have enough volume for an A cup, that's not going to be an option that's going to make you happy in the long run. So we got to look for some other way to get you to where you want to be.
One question that we had is, do you have to go to an expander before you have a deep flap done?
You don't. Absolutely. And usually we go directly to a deep flap. There are a couple of situations where we may put an expander in first. The most common reason to do that is if a patient is going to undergo radiation. So you can radiate a deep flap, but especially in women whose abdomens are a little on the small side to begin with, radiation can cause a little loss of volume in a deep flap after it's radiated. So in any person who I know is going to have radiation and ultimately wants a deep flap, I will offer them a tissue expander first. And the reason for that is the tissue expander is what gets radiated. You allow the patient usually 4 to 6 months to recover after radiation, and then we'll come back, remove the tissue expander, and put the deep flap in afterwards. And that way the deep flap is spared and does not undergo radiation. It keeps the deep flap nice and soft, so therefore the reconstruction is nice and soft. And by putting healthy tissue under the radiated breast skin by means of the deep flap, that deep flap is actually the blood supply from the deep flap is going to grow into the breast skin. It's a process called neovascularization, and that can actually improve radiated skin. And so that's another advantage for putting in a tissue expander prior to a deep flap in the event of radiation. But again, if you're not planning on having radiation, your oncology team has not clued you into that being a high probability, you most certainly can skip the tissue expander, go right to the deep flap, and get a great result.
If you did direct to implant under the muscle, can you do fat grafting 3 years later?
Absolutely. Fat grafting can really be performed at any time after the reconstruction, whether it be 2 months, 2 years, 20 years. I just saw a patient today who had an implant reconstruction 12 years ago. She's lost some weight. She has a little bit of hollowing above the level of the implants. A recent MRI showed that the implant is intact and it's healthy, and she just wants to add a little bit more volume and sort of contour the breast. And so, she's over a decade out, and I'm going to be performing fat grafting on her. So it's an option that's almost always open.
How does delayed reconstruction work with NSM and no tissue expanders?
So it sounds like it's a case where a mastectomy was done. I'm assuming NSM is nipple-sparing mastectomy. And so basically the skin has healed down to the chest wall. So you certainly can go back in, elevate the breast skin, and perform. Was the question for a deep flap?
It was, hold on, let me pull it back up just to confirm. So how does delayed reconstruction work with NSM and no tissue expander?
Okay. So depending on how much skin is still there, how long ago the mastectomy was, the breast skin can be re-elevated off of the chest wall. Probably the best option if the patient has never had a tissue expander in is to go ahead and put a tissue expander under the skin and reestablish a breast shape. Now, that doesn't mean that you have to go on to exchanging the tissue expander to an implant. You can exchange it to a deep flap or any other natural tissue flap. But it really all depends on how much breast skin is there and is it enough to still cover the reconstruction that's planned. My guess is that it's probably not enough. If you were going to do an implant reconstruction, you would definitely need a tissue expander to reestablish that pocket. If you were going to do a deep flap, you could go directly to the deep flap, but what you would probably end up leaving is some of the abdominal skin exposed. So you'd have a breast that was partially covered by breast skin and partially covered by the DIP abdominal skin. And so the scarring pattern is not ideal, which is why in that situation, I would prefer to put a tissue expander in first, reestablish the breast pocket, and make room for either an implant or a natural tissue reconstruction.
And how long do you wait to try a tissue expander after you have an infection?
How long do you wait to retry a tissue expander?
Yes.
It's usually a few months. I see the patients pretty regularly after any kind of issue. What you're basically waiting for is for the the skin to basically soften up. You want the infection to clear, but you also want the soft tissue, meaning the breast skin, to be mobile. You want the swelling to come out of the skin, and you sort of want it to be ready to move forward with the new reconstruction. So it's a little hard to say. I would say on average it's probably somewhere between 2 and 4 months.
We just had a woman, and I can answer a little bit, and then Dr. Lade, I'll pass it over to you. Does
Sure.
insurance cover a second breast reconstruction if I'm not happy with the first one?
Yes.
So yes, the
Yeah.
insurance does, and it's called a revision. And basically, you have to go see your plastic surgeon and work through the process. Or if you weren't happy with your first plastic surgeon, you can go ahead and search for a new one. And I know, Dr. Light, I'm sure you have a bunch to say on that.
Yeah. So we run into this, quite a bit. We have patients both locally from the Northeast and nationally that come to see us that may have had issues with their first reconstruction. They may have had an implant reconstruction and they're not happy with their implant reconstruction and may not have a surgeon to do a natural tissue reconstruction in their area. And so once you have a diagnosis of breast cancer or a genetic mutation like a BRCA mutation, that follows you with life, and that is used for the coding and all of the insurance authorizations that move forward. So revision to the reconstruction, even including redoing the entire reconstruction or changing the type of reconstruction, is always covered by insurance.
I had a direct to implant after a mastectomy in April. One implant was put in backwards. Does this happen often, or is this a red flag to explore other surgeons?
So it's implants. Implants can flip. And most plastic surgeons these days are using smooth round implants because of the increased risk of breast implant associated ALCL, which is a lymphoma, which has been more closely associated with textured implants. And because of that, many of us have switched to using primarily, if not exclusively, smooth round implants. So smooth round implants, especially the more cohesive gummy bear implants, can flip. And you will see this in patients, especially when they sleep on their side, or stomach sleepers, but more when they sleep on their side. And so they'll come in, they'll notice a change in their breast shape, and the implant can be often flipped manually in the office back into position. So I don't know if the question, if the if the implant was placed backwards, or if it just flipped accidentally. Either way, if it's a smooth implant, it can be flipped back into place. If it happens more than once, it recurrently happens, then sometimes we'll take the patients back to the operating room and try and tighten the pocket around the implant. So try and tighten the capsule so that it's a little bit of a snugger fit around the implant and it's less likely to flip.
Now, is it better to put the implant under the muscle or over the muscle?
So this is a very, very common question, and something that I talk a lot, both in women that already have an implant in one position or the other, or are about to undergo a implant reconstruction for the first time, and we're trying to decide which way to go after we talked about risks and benefits of each. So in my mind, the advantage of putting an implant underneath the muscle is basically the muscle helps to hide the implant. And so it's camouflage. It's just the more soft tissue you have in between the implant and the breast skin, the more natural it's going to look. And that soft tissue can come in the form of a muscle. It can come in the form of fat. But the more tissue hiding the implant, the more natural it's going to look. That's really the only advantage of putting an implant underneath the muscle. And so in very thin patients, that's more important because there's less tissue covering the muscle. And in a very thin patient in a pre-pec position, meaning the implant is on top of the muscle, sometimes you can see rippling or irregularities in the implant or the edge of the implant just because there's less tissue covering it. If you put an implant on top of the muscle, then there's a number of different advantages. Studies have shown that it's more comfortable both immediately after surgery and long-term, because many women who have implants underneath the muscle, they have this sense of tightness that the implant is always being squeezed by the muscle, and it can be quite uncomfortable. So all of that is avoided by putting the implant on top of the muscle. The other thing you avoid is implant animation, and that just refers to when the muscle contracts, it actually can push down and move the implant a little bit. And for example, if you're in the gym working out on a row machine or doing curls or any kind of exercise that's going to fire the pectoralis muscle, you can see the muscle move, and that can be certainly upsetting for patients. So putting the implant on top of the muscle avoids all of that. But the downside is it can be more visible. So you really have to assess the patient, see what their body habitus is, see how much tissue they have under their breast skin. And it's a decision that, we make together. It can always be changed. If you have trouble in one position, it could always be altered and changed into the other position, whether from on top to below or below to on top. So there's no closed doors. You sort of just have to assess what you would like to avoid the most and make that as your final, choice for the first reconstruction.
It's interesting. You brought up a good point about your pec muscle. And I have to say, you're the first person that's ever said about rowing and all of this stuff, because, when you ask your plastic surgeon, can you go back to the gym? Can you work out? Yes, but you don't think to talk about, you're rowing, you're under the muscle, and I never knew that rowing could cause, animation deformity, basically. And I never knew that, and I've never heard anybody speak about it. So it's interesting. And I think on another night, we should definitely have that conversation, because so many women that I know row, and now that I know that rowing and under the muscle really don't go hand in hand because it can develop animation deformity, why wouldn't we be educated on that? That's such a valid point.
Yeah, the gym is unique in that it's, you're usually doing exercises that have repetition. So, if you're doing 10 reps or 20 reps of something and it just keeps firing that muscle and moving the implant, it's probably the one place or the one activity where we all go where you can see the deformity over and over repetitively. And, if you're wearing gym clothing that's not super bulky, other people are going to notice. And that can be a little, upsetting and disappointing.
If a patient developed breast implant illness, can a patient remove the implants and do a DIEP instead?
Yeah, if the implants were placed for reconstructive purposes, definitely. If it was for an augmentation, then insurance would not cover a DIP for a breast augmentation. So I'm assuming that the individual's talking about they develop breast implant illness, and after a reconstruction, most definitely the implants can be removed, a capsulectomy can be performed, and then a natural tissue reconstruction such as a DIEP flap can be performed in order to finish the reconstruction.
I have under the muscle silicone implants, and I'm not a fan. Can I do a revision later to go over the muscle?
Absolutely. Yep. It's something that we do pretty regularly, both on our patients that we did implant reconstructions on, 10 plus years ago. More commonly now we're doing reconstructions on top of the muscle, but we have plenty of our own patients that we're switching, and we have plenty of patients that are coming to us that have had submuscular implant reconstructions elsewhere, and they're having animation deformities, they're having this chronic tightness in their chest, and they want relief. And so what happens is the implant comes out, the pectoralis muscle is freed up from the breast skin. It's placed back in its natural position against the chest wall. It's secured into position, and then usually more biologic mesh, such as an alloderm, is used to replace where the muscle was previously, supporting the implant in place, and that essentially makes up the switching of the implant of positions. So it's a pretty straightforward procedure. It's ambulatory surgery, and I think anyone that's out there that's having issues with a submuscular implant, I would definitely look into it, because it's a pretty easy procedure, straightforward procedure, and even at the 1 week appointment, fresh out of surgery, most women already feel better than they did going into surgery.
Is alloderm helpful for muscle showing under the muscle?
For muscle showing under the muscle, so not really, if I'm understanding the question right. Alloderm, you wouldn't put alloderm in between the muscle and the breast skin. So alloderm is either going to be used as a sling underneath the implant, where the top of the implant is covered by the muscle and the bottom of the implant is covered by the alloderm, or alloderm is going to replace the muscle and cover the entire implant. That's usually the two options for alloderm. So usually not used to hide the muscle in any way.
When a woman is under the muscle and in the process for going for a DIEP and her pec muscles rolled, have you ever seen that before?
Yeah, so the pec muscle can sometimes retract up. And so in some patients, you'll notice that the pec muscle is covering, say, 50% or even 60, 70% of the front of the implant. There are other patients where the pec muscle has retracted. It may have either released from the chest wall or released from the alloderm that was at the bottom, and it basically sort of contracts up into a ball at the top of the breast. And so in those cases, it's only covering 10 or 15% of the top of the breast. If you were going to remove the implant and then do a deep flap, the procedure would still be the same. The muscle would be released from the overlying skin. It would try to bring it out to length, to a comfortable position, and then secure it back in its natural position on the chest wall.
What to use to help hide muscle showing from my implants under the muscle?
So if the muscle is contracting and it's causing an animation deformity, there's not a whole lot that's going to hide that. You can try fat grafting if the skin is very thin over the muscle and you're really seeing a lot of detail in the muscle. You can try a little bit of fat grafting, but usually problems with the muscle where it's noticeable or an animation deformity, that's a dynamic problem, or it's a problem that happens with motion. And so really the best way to treat it is to take the muscle out of the picture, which is to put it under the implant. And so now the implant is on top of it, and the muscle has no effect at all on the implant. It'll be much more comfortable. The muscle's not under tension because there's an implant underneath it, constantly pushing against it. And the patient will just be more comfortable. So again, it's a dynamic problem, and the best thing is to just get the muscle out of the picture and put it under the implant.
Can the skin adhere or stick to the mesh?
Yes. Yeah. So if it's a submuscular reconstruction, the skin will adhere to the mesh underneath. If it's a prepectoral reconstruction, then there's probably mesh on covering the entire front of the implant, and so the skin is going to heal down to there. Where you sort of run into some problems is when, again, the skin is very thin and there's not a lot of fat underneath the skin. So every mastectomy is different. The amount of fat that we naturally have under our breast skin is a little bit different. In some patients, it's, can be a ½ inch or an inch thick. In other patients, it's, it's a couple of millimeters. It's an eighth of an inch thick. So when it's very, very thin, there you lose sort of the glide plane in between the skin and the biologic mesh, and the skin can heal down to that mesh pretty what's the word I'm looking for, pretty uniformly, and so that it's there's no glide plane. And so in those patients, you want to go back and add fat into that plane in the form of fat grafting, so that there's a little bit mobility in between the mesh and the skin, and it doesn't feel so tight.
For the overall look of reconstruction, is it best to do expanders to implant or direct to implant from a BC cup size?
If you're a BC cup and the nipple position is in an ideal position, centered on the breast, above the fold underneath the breast, then it sounds like you're a pretty good candidate for a direct to implant. Now there's, different surgeons have different preferences. There are some surgeons that just feel like they get better results with the tissue expander reconstruction. And there's nothing wrong with that. I would, when you're in consultation with the surgeon, sort of listen to what they're saying. There's nothing wrong with a tissue expander reconstruction. If you see that your surgeon is getting, amazing results with his tissue expander reconstructions, then, you may want to consider it. Yes, it can be an extra surgery, but, a lot of times with direct to implants, there may be a secondary touch-up surgery where we do a little bit of fat grafting, or, we, just work on improving the shape of the breast in some way, shape or form. So, it's, what I always tell my patients is the end result is what matters. It's not the result necessarily after the first procedure. And many times these are planned procedures. We know there's going to be a second procedure in order to get you to where we want you to be, and that's okay.
If your skin is thin, would you do an expander before you do direct to implant?
I think that a lot of times it can even be an intraoperative decision. So what I also tell my patients is that even when I'm planning on doing a direct to implant, I'll still order a tissue expander for backup. And what I mean by backup is if the patient's breast skin is very thin, sometimes the skin is traumatized a little bit during the mastectomy just by the nature of surgery. And you can have an excellent breast surgeon and still get a little bit surprised with how the breast skin looks immediately after surgery. In those cases, it's often helpful not to be super aggressive, not to put the full size implant in right away. Put a tissue expander in that's partially filled or maybe even empty, and then expand the patient over the next couple of weeks safely. Once the patient is a week or two after surgery, you can start to expand them. The skin has recovered from that initial trauma of the mastectomy, and it's just a safer position. I would hate to push the envelope, try and get away with the direct to implant in a patient where the skin may look a little, borderline and traumatized, and then have a complication with the skin. That's definitely more difficult to recover from than just being cautious from the beginning.
With new constructed nipples and implant lift after surgery, how do you save keeping a nipple shape than making it flat with wearing a bra, and wearing the bra to keep the breast intact for healing?
So after we do a nipple reconstruction, many surgeons will often do some sort of bolster dressing, whether it's with gauze or foam, or there's all different, little techniques and tricks. And the purpose of that is usually to try and prevent the nipple reconstruction from getting compressed in a bra or clothing. The reality is reconstructed nipples are always bigger initially, and they will get probably about 20–30% smaller with time. So that's just the natural progression. Nipple reconstructions from breast implant reconstruction are always a little bit thinner and smaller compared to a natural tissue reconstruction, because the breast skin tends to be a little bit thinner, and that's what you're making the nipple out of on an implant reconstruction. On a deep flap, you may be making it from the abdominal skin from the deep flap. And so I think that the nipple reconstructions will basically get a little bit smaller with time. We try and protect them in the beginning. If it's too small, they can always be revised to be made larger. So you sort of just have to allow it to heal and then see if you're happy with the results and adjust from there.
What causes the implants to be cold? My breast skin is always cold.
So many women will notice that especially during the winter months, especially if you're in a cold climate like we're experiencing right now. It's probably about 15 degrees out in New York, not like sunny Florida.
It's not so sunny here today. It was 46 degrees when I woke up,
Get
and I
out
was
of
like,
here.
it's been years since I've woken up to 46-degree weather. Yeah.
Well, yeah, 46, I'll take over 15 any day. But I understand it's not your norm. So yeah, many women will say with implants that they feel like the implants are almost a reservoir for the cold, that when they come in out of the cold, their body will warm up, but they'll still notice that the implants are still a little cold. I don't know exactly why that happens, if it's just a property of the silicone taking a little bit longer to warm up. But it's definitely a common thing that I hear, especially during the winter months.
Well, there's an option for you. Check out brilliantly.co on Instagram. She is in the process of launching a product to help women who have cold breasts. Check it out, Brilliantly Co. If you guys are listening, follow her on Instagram, as she's just launched a couple recently.
That's excellent.
So for patients who have implant reconstruction, what is the optimal sleeping position that you would recommend for them? Are there risks involved with sleeping on your side over time when you have implants?
Yeah, well, I mean, I think the really the most common risk is the implant flipping. Initially, I always want my patients to sleep on their back. Especially for the first 3 or 4 weeks, as the capsule around the implant is forming and sort of the support structure is forming, to make sure that the implants stay in place. So I definitely want them to be on their back for the first few weeks. After that, after 4 to 6 weeks, they can sleep in any position that they're comfortable in. But as I mentioned before, especially with smooth round implants, side sleepers can experience flipping of the implants. It's something that can be adjusted by tightening the pocket. And I think that every patient, listen, we all want to be comfortable. We all want to sleep. We all want to get rest. So there are some people that just, the 4 weeks that I ask them to sleep on their back is the worst 4 weeks as far as sleeping for them. And they can't wait to get back to, being more comfortable and on their side. And so, I think that there aren't any tremendous risks, just the flipping occasionally.
The last question of the night is, why do some surgeons have you wear compression garments and some don't?
Yeah, I think it's personal preference. There are, after deep flaps, I tend not to have patients wear a bra right away. I'll give them a bra. They're 1 week appointments. Other surgeons will put them in a bra immediately. I've just personally had some issues with the bras moving and adjusting and not fitting exactly like I want them to. After an implant reconstruction, I always have a patient wear a bra immediately. They wake up with one on. Some surgeons will use abdominal binders for deep flaps. You know, we do occasionally on some patients, but I don't use it for every patient. I think abdominal binders can be uncomfortable. They can ride up. It causes a lot of more discomfort than good, in my opinion, but that's just my personal opinion. I know there are plenty of surgeons that have their patients, their deep flaps, wake up with an abdominal binder on, and they're wearing one for a month after surgery.
You know, there's so many questions that keep coming through. It's just been a great night, and you know, being able to answer these questions, you know, at the ladies really thick at their tip of their fingertips, you know, is just really imperative and really what we want to do at Brock is Strong. So Dr. Light, thank you so much for coming on. And now we will definitely have to plan another breast reconstruction 101, knowing, you know, all the questions that keep coming through, and we want to give as many answers as we can. So, you know, we would love to obviously have you back on in the future, or one of your amazing partners is Nybras partnered with us over the last year. And it's really just been a great turnout and just constantly educating, making sure that every other month or every month we have the education going for reasons like this. There's so many women out there that have so many questions and either forget at their doctor's visit or don't want to send a message or don't want to ask. And I think tonight we hit a lot of those points to help a lot of women. So I really appreciate you coming on, and we definitely look forward to having you back on in the future.
My pleasure, Tracy. Thank you so much for having me. Look forward to coming back, and definitely keep up the good work. I agree. I think these sessions are critical. I think that your audience is, you know, nationwide, and you know, education is the key to making a good decision that you're going to be happy with. So I thank you.
And as we end, I do want to say that there is about 5 or 6 patients of yours on here tonight, just awing you and what amazing work you do and how helpful you've been to get them through the process, and how Nybra has really been an inspiration to them. So for all of you listening, you know, you can consider Nybra. You can reach out to them, follow them on Instagram, follow Dr. Light. And, you know, remember, just keep in mind that now today we have telemedicine, which we didn't have before. So second opinions are always available no matter where you go. And go with your gut feeling, because knowledge is power.
Couldn't have said it better.
Thanks, Dr. Light. Take care.
Thanks. Take care. Bye-bye.
Bye-bye.